Okay, here we go with the chest pain patient lecture for an advanced EMT course, which is the beginning of a paramedic course. So chest pain patient, we're going to be doing a few of these in scenarios. Here in Michigan, the EMTs are able to give aspirin and nitro as part of the curriculum. So we're going to touch on that at the end of this. But at the advanced EMT, I think that's a big addition. It's a big deal. So when we're going to be National Registry candidates and going to take a written test, and I would guess when we're doing the stations also, we should be ready to take care of a chest pain patient, be able to figure out that this is indeed a cardiac chest pain patient instead of, say, a pulmonary emboli or pneumonia patient, maybe a thoracic aneurysm, and appropriately take care of them. So we'll be running a bunch of scenarios with chest pain patients, and we should feel really good about all of those things. The next module will be cardiac, and that's where we'll learn even more and more and more about what we can do for the cardiac patient, which in the pre-hospital arena is quite a bit. So the A&P here is the myocardium must have a continuous supply of oxygen and nutrients to pump the blood. All right, we all know what the heart does, and we realize how important it is, but it eats up a lot of oxygen. All right, so when we do something that increases the oxygen demand, we should realize that they need to have a bunch of oxygen. All right. And when we're talking about the chest pain patient, one of the big things that we can do is lower their need for oxygen. And let's think about that for a little bit. How can we do that as EMTs and advanced EMTs? How do we lower somebody's heart's demand for oxygen? One of the big ways that we do that, hopefully you got it right away, is decrease the amount of adrenaline that is in the body. All right, so above everything else that we talk about today, the number one treatment for somebody complaining of chest pain is for us as EMTs to remain very calm, give the patient a bunch of assurance, go beyond just the idea that, oh, he's going to realize that we're cool and that he's going to be okay. Say it to the patient, all right, a couple of times in a non-hurried way. If you feel like you need to move with some urgency to the hospital, do that in a way that the patient does not realize that you're moving with a sense of urgency. So behind the scenes kind of work has to go smoothly. And something that I like to talk about here, a lot of times people will say, oh, we have to go lights and sirens to the hospital with chest pain patients because they need cardiac cath right away. That is not the way to look at it. All right, you should move with a sense of urgency, and that means we don't sit on scene with these patients. We're not going to sit and poke them on scene a bunch of times trying to start an IV or try and give them 3 nitro and see if that takes their pain away and then start moving towards the hospital. We have shorter on scene time. I like to go with the 1 poke and then we go. So, and we do that in a way that we're not wasting a bunch of time on scene. And then on the way to the hospital, we're going to go non-lights and sirens. And then when we get to a point where traffic or for whatever reason, we may have to go lights and sirens for a very short period of time. And then we will assure this patient that we just like to get to the hospital quickly. Maybe it's for whatever reason, all right? Not because they're unstable or they need to get to the hospital so badly, because that's going to make them excited. As they get excited, they will release their own adrenaline, and releasing their own adrenaline is just going to make things worse. So we realize that atherosclerosis or arterial sclerosis is the big risk factors for somebody who's having a cardiac event. And that's basically the buildup of calcium and cholesterol in the arteries. Athero is gruel. I think it's Greek. Athero is gruel. And so when we're talking about atherosclerosis, it's that fatty material and occlusion that's kind of easy to see, easy to understand. When we talk about arterial sclerosis, that's the decrease in the elasticity. It's the hardening of the arteries, all right? Two different terms that we kind of use interchangeably, all right? Arterial sclerosis, hardening. Atherosclerosis is the gruel, is the plaque that we're going to build up on the inside of the artery. The first thing that we'll talk about here is angina, and angina pectoris is that feeling that they get when they're having a chest problem, I should say a heart problem. And we know all of these different ways that people describe their chest pain as a crushing chest pain, as heaviness, as squeezing. It's often associated with radiating. So when we're talking about OPQRST, that hopefully it would maybe start on activity, starts to diminish a little bit as we rest. Not really associated with something that's reproducible. So pushing on the chest or taking a deep breath doesn't change the pain at all. When we're talking about the textbook cardiac, it's usually the pain is described as a 8 or higher on a scale from 1 to 10. And it radiates to the left arm, and that left arm could also be heavy, or it could be ache there. But we should realize that everybody's a little bit different, and some people have silent MIs. When we're just talking about the term angina pectoris, we're not really talking about death of tissue yet. It is just the idea that we're having heart pain. This angina pectoris is further characterized as stable or unstable. The big word to go with this is it predictable? All right, stable angina is predictable, and that is the patient's chest pain started while they were activity, and then it was relieved by rest or the first or second nitro. Unstable angina is one that's harder to predict. It starts while they're at rest, and it doesn't go away right away. All right, it may last 30 minutes. Again, when we're talking about angina pectoris, is just the term angina pectoris. That's often then associated with no death of heart muscle. It's ischemic heart muscle. It's a muscle that is crying out for oxygen, but there was never any bad injury or infarction to it. All right, there was no death to tissue. And then the acute MI is next, and that is when we're actually getting death to heart muscle. All right, and these people need to get to the hospital. This is why we have a sense of urgency when we move the patient. We want to get them to a hospital that has PCI capabilities. They're able to do angioplasty. That means do a cardiac cath and actually fix the problem. So when we're dealing with these patients, we're going to talk to them. We're going to get all of the good questioning done, and then start to treat the patient with our aspirin and nitro, and follow that up with a good differential diagnosis. The signs that it is an MI are going to include things like weakness and nausea. The patient could be sweating, that chest pain described as we did, the lower jaw, the whole arm, back, and neck pain. All of those, all by themselves, could be an acute MI. All right, chest pain with these really points towards an MI too, unless they start to describe that pain as tearing. But when it's a crushing or a heaviness, we're looking at an MI. They could have an irregular heartbeat. They could have syncope with these, and then shortness of breath. Usually not associated with their position or pain that changes. Then it might be something else. And then nausea and vomiting goes with an AMI too. Some things that you might start to think of them having a cardiac compromise and worrying a little bit more about the patient are signs of poor circulation. And that might be that they have kind of a mottled skin or their memory might be off. They're not able to answer questions as quickly as you might think. They could have shortness of breath, labored respirations, and then when you listen to the lung sounds, you might hear some pulmonary edema. Really fast heart rates above 150 are a concern, and irregular ones that might lead you to believe that they're having some ectopy or atrial fibrillation. And then the very slow heart rates below 60 are again ones that are of concern, because it kind of points towards the idea that they have this infarction or at least injury going on in fairly important places in the heart. So we worry about their blood pressure. It could be down, and then we start thinking cardiogenic shock. And with an elevated BP, we might be thinking, why is it elevated? Is it their endogenous epinephrine, or is it that they are starting to have some pulmonary edema problems? What is it that's giving them an elevated blood pressure? Very often they have a sense of impending doom, and they'll talk about, the feeling that they think that they're going to die. And then to go up with those rapid and labored respirations, they could end up having clear or pink frothy sputum as that gets worse and worse. And this would kind of go in hand with the patient who would be ended up with a diagnosis of cardiogenic shock. And the cardiogenic shock is basically what happens after a heart attack. And I usually think of it as happening after several heart attacks. And as you have a bunch of muscle that's dying, you'll have lower strength. The heart will soon lack the power to be able to push through the blood with a blood pressure that actually perfuses the tissue. And so the tissue is not going to get the oxygen that it needs, and hence shock, inadequate tissue perfusion. So if we run through the pathophysiology on this, if your heart is weak, it will start to give you a low pressure in the arterial system. And think for a second, what in our body is going to recognize low pressure? What is it in our body that recognizes low pressure? And that would be a baroreceptor. Baroreceptor, like a barometer measures pressure in the atmosphere. A baroreceptor measures the pressure in your aortic arch or your carotid bodies. So the aortic, that baroreceptor is going to recognize that, send a message to the brain through the hypothalamus, and we're going to try to correct that. All right. If it was a slight change in pressure, your hypothalamus may be just changing the amount of antidiuretic hormone. We might start seeing other things like your kidney taking care of business with some renin, which is going to give you some vasoconstriction. And I think we can stop there. Should we go on? Let's go on a little bit. If it was quite a bit of low blood pressure, that signaling is going to go to the medulla, and the medulla is going to hit the sympathetic nervous system. So then you're going to end up with some extra epinephrine in the mix, and that is going to cause vasoconstriction. That is going to increase the workload of the heart. Anytime you have vasoconstriction by itself, we're increasing the workload of the heart, and that's going to make things worse for the muscle of the heart. Here, when we get that epinephrine, that's going to have beta effects, so we're going to also be trying to increase contractility there. So sometimes when people are in cardiogenic shock and they're giving themselves their epinephrine, they'll have a high blood pressure and still be recognized as having cardiogenic shock. Cardiogenic shock is kind of difficult to explain again because it comes in many different forms. We don't need to worry about this too much, but just in way of explanation, this author here, and I forget who it was, gave it a B, C, D, and E categories. And here, some people, we may just recognize that they're at risk for cardiogenic shock. That would be somebody who later on we might be able to see that they have extensive anterior damage. But it might be just somebody who we're taking them to the hospital and this is the third time they've had a significant heart attack. They would be at risk for having pulmonary edema. They would be at risk of having cardiogenic shock. So the beginning of cardiogenic shock, the patient has some clinical evidence of relative hypotension. So very often patients will have, their norm is 138 over 92 or 98 or whatever it would be. And now their blood pressure is just lower than that. So it might not be at first jump out at us as a bad blood pressure, but that 120 over 80 could be relative hypotension for this patient. And then there's just the classic cardiogenic shock, and that's a patient who manifests with the hypoperfusion. And so they are going to be somebody who has a low blood pressure, probably altered mentation, different color to them, all of those kind of things. As we become paramedics, we'll start to recognize that this is the patient who early on may need to have dopamine. Maybe that epinephrine would be okay to think about, that push dose epinephrine. So giving these guys a big amount of volume is a little risky. We might start with that to rule out dehydration, but since they may be having left-sided problems, that would lead to pulmonary edema. And as they deteriorate, a patient that is similar to category C, but getting worse, all right? They're now deteriorating. Their blood pressures are getting worse. They're needing more reliance on medications and such. And when we talk about extremists, these are the patients that we may end up doing CPR, doing, all the ALS stuff, probably having them intubated. And then at the hospital, we'd be talking about heart-lung machines and things of that sort. So when we talk about congestive heart failure, I bumped into that a few times. That starts with left-sided heart failure, all right? So either hours or days after they've had their MI, the left side isn't keeping up with the right, all right? There is going to be a backup in the pulmonary system then, all right? If your left side fails, you get pulmonary edema. So your left side is just not keeping up with the right. I kind of picture Lucy in a kind of a classical video where she's trying to put chocolates in wrappers, I think, and she's just not able to keep up. So if the left side of the heart is not able to empty out the system and the right side keeps on doing what it does, then there's going to be extra pressure inside the pulmonary circulation, all right? Water is going to flow through the path of least resistance, and that means water is going into the alveoli. The lungs will be congested. I like to call it congested when you're not hearing rails, but it'll push over to rails or crackles soon. And that's going to make it so some of your alveoli just aren't going to work. And as we talked about in respiratory, when we were talking about chronic bronchitis, if we have those alveoli that are filled with water where we're not having diffusion, what's going to happen? And put these together, time to take notes maybe, put these together. When we have an area where the capillary membranes in the alveoli are causing, or I shouldn't say causing, but have a decreased ability to have that external respiration. We could just say the word diffusion there, but I wanted to impress you with my terminology. That's called external respiration. So when we're having that, we would have pulmonary, the pulmonary circulation right there would avoid that area. All right, and the way that it avoids that area is it constricts. It just constricts around those capillaries there. So when we have a problem with the pulmonary system, we will end up having vasoconstriction there, and that's called pulmonary vasoconstriction. If we have pulmonary vasoconstriction, that's going to lead to shunting. All right, that's shunting. That's exactly what shunting is. Pulmonary shunting is going to give you pulmonary hypertension, and if you have pulmonary hypertension, that's going to be right heart failure. Right heart failure then from a pulmonary problem, the definition, that is the definition of cor pulmonale. And that's it for all of the heart problems. We're going to talk about treatment in a little bit. Let's talk about an aortic aneurysm for short. Here, we're just going to talk about the aortic aneurysm in the chest because it's kind of the chest pain patient. So here, an aortic aneurysm is a weakness in the wall of the aorta. And here we're going to basically be talking about the aortic arch, which is just off the heart as it goes arches across the top of your chest and then down towards the diaphragm. We often, I guess you could say, we often have then an aneurysm that could disrupt circulation there. It could be susceptible to rupture, and when it ruptures, that's kind of a high mortality rate. The primary cause or the risk factor that you'd be looking for is going to be hypertension. When we have a picture here, that's that aortic arch there coming off from the top of the heart, off the left ventricle. And when we're dealing with what we would call a dissection of this thing, if we have blood, let's say the blood is going this way, when we have blood being forced through here, and that would be in this area, all right, when we have blood being forced going through this area, it's possible for us to have a small rip in what's called the tunica media. Nope, tunica intima. We would just put a little bit of blood would go this way. So every time we pump our heart, every time our heart pumps, boom, blood goes out here. All right, so we know what the stroke volume is, right? So stroke volume is around 75 milliliters. Every time our heart beats, we get 74 milliliters going this way, and just 1 milliliter that finds its way into this area where it's not supposed to be, just 1 milliliter. All right, so every time our heart beats, we get 1 little milliliter in there, 1 little milliliter every time, 1 little drop. Well, before too long, this is going to become a problem. All right, and this will very often weaken the wall, and you'll have a bulging aorta here. That bulge can go like this and become a big problem. It also can kind of bulge out like that. But let's just go with this bulging and bulging and bulging over multiple days, weeks maybe even, we'll have this. Maybe we'll get something that gives us some idea, some sort of complaint, and we'll go to the doctor and they'll see this, and then we may be able to have surgery. Very often at a geriatric age, they'll say you're not healthy enough to have surgery. So they'll let it go. But there are ways that you can fix this if it's caught. Very often it's not caught though. And if this is happening here, let's say that rip happened right here. It could happen over here, and it can happen over here too, but let's say it's happening right here. All right. If that blood is going in here, it could infringe on this artery right here. All right. Not stop it. Blood could still go there. Blood will always flow through the path of least resistance. So if our tear here decreases the amount of blood that can go there easily, the blood will just go this way. All right. And some blood will go that way. So when we're talking about a thoracic aneurysm, one of the signs and symptoms will be that the one arm will be cooler than the other, may have a different color than the other, will have different blood pressures, and maybe even a different pulse rate, or at least the feeling of the pulse at the brachial and radial. That one is an important sign to look for. The patient will complain of a tearing pain. It could be chest pain and it could be back pain. And it is a surgical emergency, so you get them to the hospital and try to keep the patient calm. Here we talk about the emergency care, and the emergency care for people complaining of chest pain is going to be position of comfort, keep them calm, give them oxygen early and often, and then we're going to start to follow our protocol. So if we think this is a cardiac nature kind of chest pain, we'd be starting with aspirin and nitro. After we get that going, we'll talk about that in a little bit, we would start doing our differential diagnosis. All right, and so what we'd say to ourselves is, what is everything that can cause somebody to say I have chest pain? And as we're starting to treat them with our aspirin and nitro and go down the Later on, we'll call it the MONA algorithm. We would want to rule out everything else. So that's where we would start saying, have you had flu-like symptoms? Rule out pneumonia, productive cough. Have you had a fever? Have you had recent trauma to your chest? A new workout or lifting things? Anything that you can think of that might be giving you chest pain other than your heart. Those are all good questions. And then other ones might be the risk factors for pulmonary emboli. And then the COPDs with just smoking. Asthma is a possibility. Just easy one to rule out by just saying, you're listening for lung sounds and you're going to say, do you have a history of asthma? They'll say no, and you'll move on, just like that. And then you'll be more assured that, yep, I'm right. This is a cardiac heart pain. And so the first drug that we give is aspirin. And again, when we talked about albuterol in the last slideshow, we talked about the idea of having a bank of questions that we ask all of the time when we're going to be giving a medication. Here, for aspirin, a good one is, have you taken aspirin before? All right, it's not a bad one for albuterol either. Have you taken aspirin before? Yes or no? Question. And then you can say, we're going to do that today. Does that sound all right? And then the questions that you want to ask, and not a bad way to start is, you can say, do you think you have internal bleeding? Because aspirin is bad for internal bleeding. And most people don't know that they're having internal bleeding. So your follow-up question would be, can you tell me about your bowel movements? How has your stool seemed lately? And if they say dark and tarry, or you can pop them with a question like, do you have ulcers? Has your doctor ever told you not to take aspirin? Then you might want to skip aspirin, right? Dark tarry stools, any indication that they have internal bleeding, you don't want to give them aspirin. Sometimes you have people who are on medications like Xarelto or Pradaxa, Coumadin, and their doctor doesn't want them to take aspirin. So a good question to ask whenever given aspirin is, how do you feel about taking aspirin? Do you take it regularly? Have you taken it before? Boom, that's one kind of question. The next one would be, has your doctor ever said not to take aspirin? And if that's true, then don't give them aspirin, all right? And then the last one would be maybe the internal bleeding. That goes without saying that you should say, are you allergic to aspirin? All right, and if somebody says, yes, I'm allergic to aspirin, a good follow-up question is, well, can you tell me more about that? Why do you think you're allergic to aspirin? And sometimes they'll have answers that have nothing to do with the allergy. They're basically saying they're just not supposed to take it. But you don't want to report to a nurse they're allergic to aspirin, and then the nurse goes, oh, you're allergic to aspirin? Can you tell me more about that? And they say, yeah, when I take aspirin, it gives me ulcers. That's not an allergy. That is having a problem taking aspirin. Nitro is next, all right? And so the reason that we're giving nitro is when somebody's having chest pain is all about having too much work with not enough oxygen to feed the heart. The heart is working too hard for the amount of oxygen we're able to feed it. So we start by giving them oxygen, and then we want to decrease the workload of the heart. Number one way of that is keep them calm. And the number two way is give them a nitro. Nitro is going to, a big, $6,000 word or phrase for this is it increases venous capacitance. And so by increasing venous capacitance, it will allow the blood to sit in the veins. So it dilates those blood vessels, and then less blood returns to the heart. If you decrease the amount of blood going to the heart, you're going to decrease the workload of the heart. Nitro does a little bit of this. It may, and I don't like to harp on this too much at all, but it may cause some coronary vessel to run smoother, all right? It may cause a little bit of dilation there. So if you have a blockage, it might help blood get past that blockage. We shouldn't think of that. A lot of times EMTs are taught that. That's a very simple way of looking at nitro, all right? patients will say that that's the reason they take it. But we need to have a better understanding. We should understand that it causes the vessels in the body to dilate, and that decreases how much blood returns to the heart, and that decreases the workload, so it decreases the pain. The contraindications for nitro, which are important to pay attention to, is that systolic blood pressure below 100 and the use of ED drugs within 24 hours. Head injury is one that's a little bit different. We shouldn't be thinking of this when we're just dealing with a head injured patient. Some people will say, well, this head injured patient has a blood pressure of 210 over 130 and I want to lower their blood pressure. And nitroglycerin can kind of predictably lower your blood pressure. We would never, ever, ever want to give somebody nitro to lower their blood pressure, and that's the only reason. We as pre-hospital providers allow people to have high blood pressures, all right? Even in the ER, they don't immediately address high blood pressures until they've ruled out the need for that blood pressure. So if they had a stroke, let's say, and they have some mass in their brain, whatever you want to say, they need to have that increased blood pressure to perfuse their brain. We don't want to take that blood pressure away. And then we give 3 doses. After 3 doses, we'll want to ask special permission for extra doses of nitro. A little bit about that 100 millimeters for the systolic blood pressure. If you're talking about a small framed patient or a patient who says, my blood pressure is always 100 or 98 or whatever, then nitro might be back on the table. What you might want to do as an advanced EMT is make sure that you have your patient on the stretcher, maybe in the semi-Fowlers, and maybe even an IV started before you give the nitros. We can give aspirin to any kind of blood pressure, but when you have a blood pressure that you're worried about, maybe better to make it so the patient is in a position where you can easily lay them down if their blood pressure goes down, and then maybe give them a fluid bolus. So we also start IVs on these patients. We don't start IV locks. And that is it for the chest pain patient. We might want to just talk about that side effect of a headache. We should tell the patient beforehand, hey, this is nitro. It causes vasodilation, and that gives people headaches. All right, so you can expect to have somewhat of a headache when I give you this. And we should also expect that blood pressure change, so be checking blood pressures early and often after nitro administration. And that's it for the slideshow. Hopefully all of that was fairly easy to understand. If you have any questions, please leave them in the comment section, and I will try and get to you. Take care.